Dr. Thomas Frazier is a licensed clinical psychologist who received his BS in psychology from John Carroll University in 1997 and his PhD from Case Western Reserve University in 2004. He joined Cleveland Clinic and until recently was the director of the Cleveland Clinic Center for Autism and an assistant professor of pediatrics in the Cleveland Clinic Lerner College of Medicine. In April 2017, Dr. Frazier joined Autism Speaks as Chief Science Officer. Dr. Frazier's clinical interests include diagnostic evaluation as well the use of intensive behavioral intervention to improve functional outcomes for individuals with autism. His research has focused on two areas: improving early identification through the translational studies of a genetic subgroup of autism associated with P10 mutations. Dr. Frazier is also the father of a 13-year-old son with autism. Please welcome Dr. Frazier.
Thank you. I didn't realize my bio was so long. I have a bad cold, so I'm going to go fairly quickly, and maybe we can have time for questions if we have enough time. My goal is simply to run you through the association between P10 mutations and autism, and to give you a little bit of background on the work that I did with Dr. Karis Ang while I was at the Cleveland Clinic, and that has culminated in the longitudinal study that you learned about earlier. So autism, unfortunately, is a fairly prevalent disorder now, and we're seeing it more and more in individuals with P10 mutations. In terms of the criteria for autism, I get asked fairly frequently what is actually autism. It turns out that it's sort of two things that are happening together. One is these social difficulties, and the other is this repetitive behavior that you see. It is a spectrum. We see folks with autism who are very high functioning, oftentimes quite brilliant, all the way down to folks with autism who have intellectual disability and everything in between. And the DSM-5 came out a few years ago, and they changed things around a little bit. They consolidated some of the specific diagnoses like Asperger's disorder into a single autism spectrum disorder. And on the slide you can see the different criteria. I think the most important thing to just understand about autism is that it's these two things: social, particularly social perception and social attention, and then also this getting stuck on things, repetitive behavior, restriction of interests. And the symptoms have to be present, or may be present by history. They have to impair functioning across settings. So this isn't something that we give willy-nilly as a diagnosis. It has to be impairing to individuals across multiple settings. And then there's this new disorder called social communication disorder. And basically what social communication disorder is when you have the social difficulties of autism, but you don't have the repetitive behavior or the getting stuck behavior in autism. It is a spectrum diagnosis, and what we mean by that, what we mean by that is that the specific diagnoses that we used to give, like Asperger's and PDD-NOS and all of these old diagnoses, they actually really aren't separate things. They aren't different things. When people studied this, they found out that you couldn't reliably diagnose between them. And so that's why we went to autism spectrum disorder. There's a concern that we might have missed some high-functioning cases. It turns out that we probably aren't missing too many high-functioning cases, if at all. Ultimately, when you think of autism, I just want you to think of these two things, these sort of unusual problems with unusual behaviors on the bottom. They can be obvious, like I'm showing here in the figure or in the video, or they can be less obvious. It can be more like, I like to talk about something over and over again because that's the particular topic that I'm interested in. And then on top of that is the social difficulties, and those can be more obvious, for example, just not wanting to engage at all socially, or they can be a little bit less obvious, like social distance. I get a little too close when I talk to people, or I have difficulty with making eye contact, or making sure that I'm reading your affect. If you've ever been in a conversation with somebody and they didn't seem to understand that you were done with the conversation, that's sometimes what you see in people who have high functioning autism. The prevalence of autism is rising. It used to be 1 or maybe 2 or 3 in 10,000 in the 80s. Now you see that autism is much more prevalent, 1 in 68. I think in the next month, the CDC is going to release new prevalence estimates. We don't know if they're going to hold steady like they did in 2014 or come up a little bit, but so we're not quite sure where that's going to go, but in the next month we'll have more data on that. I get a very frequent question of why is this? Why is autism becoming more prevalent? And the honest answer is that for at least a large number of cases, we don't know. But there is greater awareness. That's a piece of the pie. The fact that we're waiting longer to have kids is also a piece of the pie, it seems like. And then also we're taking other diagnoses and we're putting them together with autism. So for example, kids used to get diagnosed with mental retardation or intellectual disability, and now they're oftentimes diagnosed with intellectual disability and autism. That's called diagnostic accretion. I'm not going to go through the evaluation too much because most of the people in this room probably have already experienced this or have some understanding of it. I do want to mention that there are a number of different ways to screen for autism, and that the MCHAT is probably the most common. It's given at 18 and 24 months in a lot of pediatrician practices or family practices. We do offer an MCHAT online through Autism Speaks. If you go to the website, autismspeaks.org, you can find the online MCHAT. But there are other ways to screen for autism in older kids as well. For example, the Social Responsiveness Scale, the Social Communication Questionnaire, and there's a new interview-based measure that probably is a little bit more useful, and it's called the Autism Screening Interview. If you go to get your child evaluated, or if you go to get evaluated as an adult, we usually try to get people in to see multidisciplinary teams. The reason is because autism is oftentimes associated with all kinds of other things, and certainly in the case of P10, it absolutely is associated with other things. But the key elements here, and I highlighted them and bolded them, is you want to make sure that you see this multidisciplinary group of people that have experience in autism. You want to make sure you get a clinical observation measure like the ADOS completed, and you also want to get cognitive and language testing in your clinical evaluations. Now, if you participate in the longitudinal study or even the clinical trial, you'll also see that a lot of these same measures are used. Autism goes along with a number of co-occurring conditions. In the case of P10, we know sort of why that might be the case, but in the case of autism without P10 or with idiopathic autism, we don't know exactly why that is, but there are all these co-occurring conditions associated with autism, and we need to do a much better job of understanding how to deal with them and improve the quality of life of individuals around these co-occurring conditions. But when people are diagnosed with autism, it's not unusual for them to get diagnosed with 1 or 2 or even 3 other medical or mental health conditions along the way. Our Autism Treatment Network, which is funded through Autism Speaks, has found that medical comorbidities can worsen behavior problems. And so in this example, we see a lot of sleep problems in folks with autism. And yet when people don't have sleep problems, their behavior tends to be, a little bit better than when they do have sleep problems, when their behavior worsens. And so unfortunately with autism, when you do get one co-occurring condition, it oftentimes can spiral and create other difficulties as well, especially sleep, because sleep is so crucial to our daily functioning. And we found that people with autism, families affected by autism, tend to have lower quality of life than families that are not affected by autism. And the blue bar there, the non-ASD bar, these are families who have kids with other conditions. So it's not like these are just neurotypical families. These are families with other problems, conditions, but the child doesn't have autism. So there's something particular about autism that decreases family quality of life. We see a huge range of outcomes in autism, from high to low functioning. I mentioned that before. When we talk about high and low functioning in autism, we're really talking about cognitive level. And so getting that cognitive testing can be really important, not just for understanding where your child or you are at, but also for planning the next steps in your life, whether it be academically or vocationally. Receptive language and nonverbal abilities are really good predictors of outcome. So knowing those cognitive scores can help you to plan as a family for what your child is going to need. I have to acknowledge Dr. Karas-Eng. I think people don't realize how much of science can be serendipitous, but Dr. Eng, because she has a strong clinical eye, was really the first person to identify that in her families with Cowden syndrome, with P10 mutations, that there was one too many kids that they were having with autism. And it's that clinical observation that actually has us all in this room here. It's just that sort of astute paying attention that Dr. Eng did. And so her group was the first folks to publish a paper on children with P10 mutations with autism. And since then, I think Karas and I worked together for 8 or 9 years on this problem, on this issue, and this condition. And so I just wanted to give you a flavor for some of the things that we found, which have been alluded to a little bit earlier in some of the conversation, but I'll give you a little bit more clarity on that. I should mention, though, that there are a number of other groups that have looked at this issue, and so it's been well replicated. In fact, P10 is now well understood to be a major risk gene for autism and intellectual disability. Dr. Eng encouraged me when I was at the Cleveland Clinic to work with her to study these patients and individuals, and we collected a cohort. We have a much larger group now, but when we published this paper back in 2015, we had 17 individuals with P10 mutations with autism, and then we compared them to other patients with autism, whether they had a big head or did not have a big head, as well as healthy sibling controls. And we found some interesting things, and I think they're holding up pretty well so far. But we'll know more when the longitudinal data comes in from the trial, from the study that you heard earlier. One of the things that we saw was obviously very large heads, which is not surprising to this group, but also that their autism symptoms, at least at a gross level, seem to be fairly consistent with the other groups of patients with autism. There were no major differences in autism symptom levels among the groups. We did see this big increase in white matter that Dr. Eng alluded to earlier in the P10 group with autism. Unfortunately, we didn't have a P10 group without autism in this cohort, but now we're collecting that through the longitudinal study. We also saw that there were these dark spots on the MRI scans, and I'll show you these in a minute. They're called white matter hypointensities, and they're probably spots where the white matter hasn't fully developed yet. And so we're seeing a lot more of these in the P10 group than in the other groups. And you can see these on the images. These aren't even great scans, but you can still see them on these images, these white matter dark spots. And we saw these all the way up into the 20-year-olds that we had in our sample. So these are typically, you do see these dark spots in neurotypical individuals, but only up to about age 2. Then they disappear. You don't see them anymore in the MRIs. But we were seeing them all the way up until the 20s in folks with P10 mutations. And we also saw that folks with P10 mutations with autism had more difficulties with processing speed and working memory. Even when you accounted for those IQ changes that Dr. Sid was talking about earlier, we still saw some reductions in working memory and processing speed. So the new study that was conducted, the RDCRN study that Dr. Sid talked about earlier, we decided to collect a number of different neurobehavioral measurements as well as eye gaze. And unfortunately, I don't have a large number of patients to tell you about, individuals to tell you about, but we do have some data here. Our first study I mentioned already was the 17 individuals with P10 mutations with autism. And then our next study was, we had a much smaller sample at the time. The sample has grown since I've analyzed the data, but at the time we had a much smaller sample. But we had some different measures to take a look at, so I want to tell you about those now. One of them was our eye tracking task, and I think eye tracking is a really promising tool for evaluating attention in people in general, but especially people with autism, because we can look at where they're looking, and if they're looking at the social regions, that's expected behavior, and if they're not looking at the social regions, that's unexpected behavior. And so we can quantify this, and in fact, we can look at the very, very detailed level to see where people are looking or not looking. and see whether or not the pattern that they're showing in their gaze is the expected pattern or if it's different than the expectation. And so when we started to look at the data, all the data that had come in, we were not seeing any differences in autism symptoms. So again, we just didn't see big differences on autism traits or autism symptom levels between the folks with P10 ASD versus the folks with other groups. We also didn't see any differences on clinician-rated autism symptoms either. Now, I will mention, and I said this last night when we were talking to folks, that we haven't taken a really super detailed look at all the little items and the individual different behaviors. And maybe we'll see some differences when we look at the individual behaviors, but so far we haven't seen any differences. But where we have seen differences is captured on this screen. We see that folks with P10 mutations with autism certainly have a lot more gross motor difficulties and also fine motor difficulties than the other groups that we collected in our first study. We also see something that I did not anticipate, but it made a lot of sense to me when I finally looked at the data, because we had seen so many patients with P10 mutations with autism that it finally dawned on me that the patients that we had seen, they were much easier to work with than our other autism patients. In general, they were just much more easygoing, easier to test. And we even had some parents, when we do these long developmental interviews about their birth history and their early development, some of the parents over and over would say the same thing to us, like, oh, he's such an easy baby. He's a real easy toddler. And never really dawned on me to hypothesize about that, but we did see that the P10 group had much lower levels of emotion dysregulation or externalizing or whatever you call challenging behavior. And so this is very unique, I think, to the particular patients that we saw with P10 mutations with autism. We did see more problems with sustaining attention in folks with autism with P10 mutations as well. So keeping their attention focused on a particular task seemed to be a bit harder. But we didn't see differences in other areas like quality of life or emotion recognition. When we looked at that eye gaze task that I showed you earlier, we saw that the folks with autism with P10 mutations looked a lot less at the social regions of interest. So in this case, the female face and the male face. In fact, we saw reduced gaze to the social region in 3 out of the 4 stimuli that we analyzed. And so we're seeing a very similar pattern in our P10 ASD group to our other ASD groups, meaning that these folks look less at the social regions of interest. They're not paying as much attention to social behavior as we would expect them to. So I want to summarize really quickly here what we found. We did see problems with sustained attention, processing speed, and working memory in folks with P10 mutations with autism. And when you add these cognitive problems up together, it does seem, at least in our initial data, that that's what's causing some of the reductions in IQ. It's these specific cognitive difficulties with sustaining attention, holding information in mind, which is working memory, and then processing information quickly. The gross motor dysfunction that we saw is, I'll say, almost ubiquitous. I didn't see a patient with P10 mutation with autism who did not have a gross motor dysfunction. And fine motor dysfunction was also very common. As I said, we saw a lot less emotion dysregulation. Our autism symptoms didn't seem to be any different than the other autism cases we had collected without P10 mutations, but the eye gaze patterns that we saw were very reflective of the general autism pattern. So there wasn't anything specific about the P10 mutation in terms of eye gaze. It was much more related to the fact that they had autism, that their gaze to social regions was different. There's a lot more work to be done here, but I do just want to follow up with some intervention and recommendations for families and parents who have children with autism with P10 mutations. First thing to be aware of is that we're always looking for interventions for our kids, right? We want our kids to do better in whatever they do. We want to help them as much as possible. And we do know that developmental and behavioral interventions are effective for people with autism, regardless of whether or not they have a P10 mutation or not. And so if a child has autism, we want them to get these developmental and behavioral interventions, whether it's the Denver Early Start model, or if it's pivotal response training, or ABA, which many people have heard, applied behavioral analysis. We want kids to get these intensive early interventions, and then if they need it, ongoing behavioral and developmental interventions. We also know that parent training helps, and Dr. Harden actually is one of the first people to demonstrate through randomized trials that if you get trained as a parent in these behavioral interventions, that your children are going to do better. They're going to learn how to use language and communicate better. They're going to function better in the world. So in terms of P10 specific conclusions, though, a couple things I just want to mention, and then I'll stop, and if there are questions, I can answer some questions. But first of all, those imaging findings I showed you earlier and some of the differences in processing speed and working memory, we think that those can be really useful measures for future medicine trials, and that's why in the clinical trial that Dr. Harden talked about earlier, we've included those measures in that trial. In terms of educational or treatment approaches, because a lot of people with P10 mutations with autism do have slower processing speed and working memory difficulties, we think that it's really important when you communicate with them that you don't want to speak too quickly. It's better to slow down your speech, use slower, shorter communication bids, ask more attention questions, because there are patients with P10 mutations with autism that we saw where if you just looked at them and you just talk to them, you might be given the misimpression that they were gathering all the information that you were giving them. But in fact, they were missing large chunks of information, and so you really need to ask attention questions and make sure that the child is attending, or even if they're an adolescent, that they're attending. And that repetition is really key to memory retention, and so you want to make sure that you do repeat directives or information that you're giving. Make sure that teachers are aware of this as well. Because people with P10 mutations with autism are much more docile, easier to work with. In school, they're probably easy for teachers to work with. That doesn't mean that teachers don't have to go the extra mile, though, to make sure that they're retaining information, that they're attending appropriately, and that everything that's being communicated to them is being received. And then I would, of course, always recommend an early referral for occupational or physical therapy because of the motor difficulties. So thank you very much for your attention. It's up to you guys if you have time.
Anybody have any questions?
Hi, my son is 8 years old. He has benign P10 with autism. You mentioned many of these babies were seen as very easy babies. My son didn't walk till he was 2.5 and has very low muscle tone, PT, OT. We had him in a Riften walker. So fatigue is a major issue. So do you think, is that part of why people perceive these babies as being easy? Because really their fine motor, gross motor is so delayed. They just get fatigued. He takes frequent breaks all the time.
Yeah, that certainly could be part of the reason. I wasn't thinking about combining the motor with when I was saying people talked about them being easy, but I think you're probably onto something there. I think more than anything, it was that, relative to the rest of the autism population that we see, most of those other folks with autism, they really have difficulties with need for sameness. So if anything changes in their routine, there's a tantrum, and we just weren't seeing that in the P10 cases that we were seeing. So that could also be part of it, but I do agree with you that there's probably some of this motor that plays into it. They're kind of a little bit easier, except obviously they need physical and occupational therapy to improve those difficulties, but there could be something to that, not having that hyperactive energy kind of that causes parents to have to deal with them in particular ways.
I've heard this whole life from teachers and providers, he's so easy to work with. Well, he gets fatigued after 5-10 seconds.
Right.
So, yeah.
It might not be a lot of benefit to throw a tantrum when you're going to be fatigued 10 seconds into it or something like that. Yeah.
We're doing the evaluation for kids that have P10 with autism. Do you notice any difference with getting an actual diagnosis because of that easygoing attitude that they have?
Yes, I do think that that's why I emphasize going to a multidisciplinary clinic that really understands autism, because unfortunately there are some people that could be sought out as providers to give a diagnosis who mix up two things, the level of difficulty in terms of externalizing behavior and the actual autism symptoms. And you don't want to mix those two things up, because yes, there are a large proportion of the autism population that has those extra behaviors, those challenging behaviors, but those aren't core autism symptoms. And so unfortunately, if a person with P10 gets to one of those providers and they don't see those behaviors, they may not give an autism diagnosis. And that's unfortunate in my opinion. You really have to look very specifically at the social communication difficulties and the restricted repetitive behaviors when you make the diagnosis. And I think multidisciplinary clinics are going to be a lot better at that than some other clinics will be, or individual providers will be. Thank you.
Thank you, Dr. Frazier. Okay, we're going to go rogue for just 1 minute. Claudia.